Hi, everyone. My name is Patrick Doyle, and I'm the Senior Vice President for Track Manager Credentialing. And we're excited to once again be working with MGMA, albeit this time in a virtual environment. Track Manager has developed and deployed the nation's premier provider onboarding platform, delivering automation from provider contract execution through initial credentialing and provider payer enrollment. Our solution blends proprietary cloud-based IT solutions with world-class services backed by our NCQA CR accredited operations team, and has been nationally recognized 2 years running by Black Book Market Research as the #1 provider of outsourced credentialing, privileging, and enrollment services. On behalf of Track Manager, I'm happy to introduce the session on coordinating the optimal referral experience, and we look forward to you visiting our virtual booth.
Hello, everyone. My name is Andrew Haiti. I'm the Assistant Director of Association Content at MGMA. Welcome to today's session, Project CORE, Coordinating Optimal Referral Experiences. We have a few reminders before we begin. You can claim ACMPE, ACHE, CME, and CEU credit, and if you view the live session, AAPC, CPE, and CNE credit. Claim continuing education credit starting next week using the MGMA CEU portal. The code for AAPC credit will be emailed to you. To view the chat area to the right of the main share screen area, select Exit Full Screen, then select Chat. Submit your questions, resources, and comments using this chat area. Slides and resources can be found in the lower left section of the previous session page. The education for this session will now begin. In today's session, Dwayne Pearson, MD, Medical Director, Echo Colorado, and Associate Professor of Medicine, Rheumatology, University of Colorado School of Medicine, and Matt Thompson, MBA, Operations Administrator, University of Colorado School of Medicine, will discuss how e-consults are used to increase patient access to specialty care services at their organization. Dwayne and Matt, I know you've got a lot of great information to share, so I'll turn it over to you.
I'd really like to thank you for that introduction, and I'd like to thank MGMA for having us here to be able to talk about a project that we've been working on for the last 2 years. I'm Dwayne Pearson, and Matt and I are joining you from Colorado to talk about Project CORE, Coordinating Optimal Referral Experiences, and how that's influenced our capacity at the University of Colorado to deliver healthcare. By the end of this talk, we really hope to be able to talk about how we believe our eConsult platform that we developed in partnership with the School of Medicine and the American Academy of Medical Colleges creates a new value proposal for our patients, providers, the system, and payers all alike. We're going to look at how we were successful in this implementation, looking at volumes, looking at finances of this project, and then lastly, looking at how the ROI works in both a fee-for-service and value-based care model. So in our agenda, we're going to take you back to what is the problem we were trying to solve, and then how we came to partner with the AAMC in this solution, and then get into the specifics, the granularity of how this actually works within our electronic medical record and within our system. So I spend most of my days as a practicing rheumatologist. I've been doing this for about 2 decades. And I have to say that what I see in clinic at the University of Colorado is very similar across trends that we see nationally. As the complexity of healthcare has increased, the frequency of referrals have gone up, but at the same time, we recognize that some studies have said up to 40% of specialty referrals don't need to be addressed on site or can be addressed in other means. We have challenges in terms of asymmetry of our specialty workforce across the country, and little has been done to address or move us beyond what is a traditional brick and mortar system, where primary care puts a referral in, patient drives multiple miles, they show up, and maybe there's data on site. We know that patients are living longer, and as part of that, they have more chronic healthcare conditions. And it's now 40% of the US population has one or more chronic condition, which actually accounts for the majority of our hospitalizations. That's aggravated by delays of care if there is difficulty in those care transitions from primary care to specialty care. 91% of all prescriptions are filled are related to specialty or chronic conditions that typically have some type of specialty care need. And 76% of all physician visits are for chronic conditions being managed. So to recap, Not all patients actually need to be seen by specialists. However, our referral volumes continue to grow. And the question comes back, why do we only have one level of service or one level of care to offer to patients? Aren't there opportunities to actually move data instead of move patients? Aren't there opportunities to actually move beyond what is an antiquated system into a virtual health neighborhood? So we believe that e-consults are an effective way to move the communication from the primary care clinic from that primary medical home into specialty care networks, have that data and that question then addressed by a specialist and then acted on by a primary care. That's the essential architecture of an e-consult. And then in instances where that level of care might not suffice for what the patient or provider needs are, how do you convert that over to a referral that will get that patient to be seen in the most timely fashion? So Project CORE was initially launched by the AAMC with partnership with the University of California, San Francisco. And essentially, it puts the primary care and the patient in the center of a web of healthcare, where that primary care is defining in discussions and in collaboration with the patient, what is the level of care that they need? It might be that both of them agree, yes, we need a specialist to be able to be involved in this care. We think that you being seen on site is appropriate. But then working through what we call an enhanced referral, which is essentially decision support embedded in that referral template, it helps move that data and make sure that that first visit for that patient is as high yield as possible, with the end goal being that patient and primary care provider's question being answered in one visit, versus a distinct question that the primary care and patient are comfortable posing to a specialist without that patient being seen on site. And really, the recommendation being based on data available and perception of the medical question as outlined by the primary care doctor. So an e-consult versus an enhanced referral. So really, when you look across this, the goals of Project CORE are completely in line with the quadruple aim, which is decreasing costs, improving the patient experience, decreasing redundancy, which is of course part of decreasing costs, improving the provider expectation or provider experience, and then lastly, improving the health of the community. By recognizing that about 40% of healthcare can occur in the primary medical home, that actually improves to better access to specialists and moves everybody to practicing healthcare at top of scope. I'm going to hand it off to Matt here to really get into the nuts and bolts about how we did this on site.
Yeah, thank you, Dwayne. My name is Matt Thompson, as mentioned earlier, and I've been leading this project at Anschutz Medical Campus since our initial investigation of the project back in 2017. And it's actually been really fun to lead this project and see its growth, both on the adult health and the pediatric side over the last 3 years. So as Dwayne mentioned, in 2017, Anschutz Medical Campus, which consists of University of Colorado Hospital and Children's Hospital Colorado, we all partnered with the Association of American Medical Colleges to essentially learn from them about how different sites across the country implemented Project CORE and learn from their successes as well as their failures and implement that system within our EHR and on our campus. In 2018, we launched with 8 adult health specialties and 7 child health specialties, rheumatology being one of those. As Dwayne mentioned, our e-consult program allows the primary care doc to either during a in-person visit or after that visit say, I've got a non-urgent clinical question. I think with the help of a specialist providing me some education on my clinical question and recommendations on how to manage the particular condition that I have a question on, I can avoid an in-person referral and manage that patient in my primary care clinic. And the expectation is that the PCP, when they send off their e-consult, they're going to utilize decision support within the EHR that includes things such as, please include this information in your clinical question. What is the duration of the issue at hand? What are the symptoms the patient's having? What is the history around that particular condition? What treatment has been tried? And the workflow also allows for the primary care doc to upload any sort of image that may be relevant to the clinical question they have, as well as pull in labs or images, or labs, tests, or images that are related to a specific condition. So each specialty that's live has a unique set of templates that capture about 80 to 90% of reasons why a PCP may refer to that specialty. And each specialty has about 5 to 8 templates that the PCP can click on in order to send the e-consult. And again, they follow decision support that allows for a very efficient clinical question to be sent to the specialist, and allows that specialist to be able to answer the e-consult without having to dig through the chart to find the information they need. The expectation is that within 3 business days, the PCP will hear back from our specialist on whether they're going to recommend the treatment for the clinical question, whether they're going to decline the e-consult because it's too insufficient in nature, or maybe it's a logistical question that's posed, or the specialist can convert that e-consult, meaning the primary recommendation from the specialist is to have that patient be seen in clinic. So we'll get into that workflow in a little bit, but that's basically the build that kind of launched this project and helped us expand from 2018 to 2019. So in 2019, we expanded the program to 13 additional adult health specialists and 8 additional child health specialties. And there are community-based practices, both on the adult health side and the pediatric side, that license Epic from Anschutz Medical Campus, UC Health, or Children's Hospital. So we expanded to community-based practices that have patients of all different payer types, both in the Metro Denver region as well as the Frontier region. So we really took a concept that was embedded at Anschutz Medical Campus and expanded it across Colorado. And as we'll get into the data a little bit later, you can see that we've had e-consults placed on quite a few patients across 36 different counties in Colorado. So far in 2020, we continue to expand to additional adult and child health specialties. At this point in time, we've pretty much concluded our expansion internally with specialties. We're about 27 live adult health specialties and 21 child health specialties. We do continue to expand the community-based providers that license instances of Epic from Anschutz Medical Campus. But one of the key things we just launched this month in September of 2020 is utilizing a third-party platform to create interoperability between different EHRs. So there's a federally qualified health system in the Denver region that's on a different EHR than we are. And within this third-party platform, the primary care doc at this FQHC in the community can log into their EHR, and with single sign-on, they can send an e-consult utilizing what's called Arista MD, that third-party vendor's platform, and that e-consult transfers over to our specialist Epic in-basket, and our specialists are able to answer that e-consult. So we now have the functionality to allow for e-consults to be sent within Epic, as well as through a third-party vendor that has EHR interoperability, which is pretty impressive work. And that opens up the playing field for a lot more community-based practices to be able to send e-consults, which at the root of this problem is helping increase access to specialty care. So when you take a look at what it took to make our Project CORE happen, some of the investments that were made include a physician lead time. So we have a primary care doc who's a champion on the project, and we also have Dwayne as a specialist champion on the project, and we fund a portion of their FTE to keep our project up and running and sustainable. We have an executive sponsor who was the Senior Associate Dean of Clinical Affairs, and she was really the driving force behind making decisions to implement e-consults on our campus. We have a quality assurance analyst. We do QA work weekly on all of our e-consults, making sure that the clinical question is complete, making sure that our clinical responses are complete and timely, and then just making sure that any sort of feedback we can provide to the PCPs or the specialists in terms of enhancing e-consults or making it more efficient, we're able to do that through our QA process. I was the project manager on the project the last 2 to 3 years. That was a 1.0 FTE effort. And we also worked with our Epic team, of course, to launch this workflow. Obviously, without that Epic team, we wouldn't have been able to create this workflow that has allowed for this efficiency and effectiveness of our e-consult program. And we've also partnered with Echo Colorado, which is a platform that allows for education and engagement across the provider sector, which brings our PCPs and our specialists virtually together to talk about use cases of e-consults across whatever specialty we decide to highlight in that quarter. So for example, if rheumatology was the highlighted specialty, we'd allow for PCPs to come together and ask Dwayne and his colleagues who are answering e-consults about specific use cases. Why is it in this particular example you thought an in-person visit would be better than answering the e-consult? Or what is it that I can do ahead of time as the PCP to make my clinical question more efficient in hopes that there's greater chance that that e-consult gets answered by the specialist? So we went live, as I mentioned, in 2018 with quarterly waves of specialties. So every quarter, we tried to bring on 3 to 5 additional specialties. So a rolling implementation from 2018 to the beginning of 2020. We've had over 6,500 e-consults placed. 75% of those are completed, meaning that the specialist has a clear recommendation for the PCP to treat that clinical question in the primary care setting. 18% of our e-consults were converted to an in-person visit. That means the specialist, with a click of a button, can take an e-consult and turn it into an in-person visit, where that's routed to the referral authorization center, and it's also routed to the scheduler to schedule that patient. And the reason for that decline, again, is that the specialist deems the e-consult to be too complex, or that the patient would benefit from an in-person visit rather than back and forth via an e-consult. And then we have a 9% decline rate. And what that means is that the PCP is forgetting to include some relevant information in their e-consult, or it could be a logistical question. As we've grown our e-consult program, particularly community-based providers, there's a lot of education that goes into that. So there's a large ramp up on getting PCPs trained on how to send e-consults. They're going to have a higher chance of being completed. So that number reflects a lot of training that's gone into educating the PCPs on how to send good good clinical questions. When you look at the percent of patients that are treated via an e-consult or referral, roughly 8.5% of specialty contact for all core patients are e-consults. So that means roughly 1 out of every 10 patients are treated via an e-consult. When we look at gas savings specifically, not looking at other indirect costs associated with e-consults, but just looking at gas savings, where you're looking at what is the mileage from patient zip code to Anschutz Medical Campus and back, and taking that times the IRA gas reimbursement rate, it's over $75,000 in gas savings to patients alone, which is pretty eye-opening and shows that there is some sort of ROI, at least to argue in favor of continuing e-consults. And throughout COVID, we all know that ambulatory visits decreased, but we had a consistent use of e-consults through COVID. So even as as hectic as things were in the months of March, April, and May, our e-consult volumes didn't drop. They maintained consistently across those months. And then actually we've rebounded since COVID with the last 2 months with higher than normal volumes. So when we look at our core participation, we have about 600 providers who have the ability to send an e-consult. Again, 26 live adult health specialties and 21 child health specialties. I mentioned our e-consults have a 3 business day turnaround time. And that's the expectation that specialists respond within 3 business days. But actually 81% of our e-consults are answered within 2 business days. And that's very powerful data, because when you look at some of the average time to appointments across some of the specialties, you're looking at endocrinology 44 days, cardiology 87 days. The value of the e-consult allows the PCP to know within 3 business days one of 3 things. 1, that patient's going to have that provider's going to have a recommendation on how to treat the clinical question. 2, that patient's going to know they're going to get a call from that specialty letting them know that they will be seen and scheduled in clinic. Or 3, that the PCP needs to rewrite their clinical question because perhaps it's insufficient in nature. All of those options are much better than the turnaround times that Dwayne had mentioned in this first slide, where we talk about access to specialty care being a problem. So significant value, not only for the PCP, but obviously the patient when e-consults are available. So I'm going to turn it back over to Dwayne to walk through what it looks like from both a PCP perspective and a specialist perspective within Epic, specifically our build within Epic, on how to send an e-consult and how to answer an e-consult.
Thanks, Matt. I just can't say enough how excited I am about this. I mean, it is really, I love answering e-consults. And the reason is, right now in healthcare, frequently we're balkanized. You have your specialty clinics, you have your primary care clinics. There's really no medical lounges anymore. There's very little time for people to talk to each other. I don't know what you know as a primary care doctor, and I don't know what you might be thinking frequently. And sometimes the amount of time that it takes to put in a referral to get it all packaged up is typically uncompensated time. When you look at what's happening with Medicare now, both primary care and specialists can be paid to communicate, to be able to try to save that patient a trip, to try to save that patient excess testing, to try to answer questions more quickly. And the secret to it is having a highly formatted exchange. And so as we started to build this out, every specialist worked through typical templates on what were questions that they thought that could be acted on, answered first by just data, and then acted on by primary care in the primary medical home. And from that, then data dictionaries were developed in terms of what is the data that needed to be drawn or collected in the primary care setting, and then how is that best communicated. It all starts actually with moving into the order entry. And so in the same way in your electronic health medical record, where you would actually enter in an order for a referral or a test, that's where the e-consult e-referral lives. And so this is an example of how you would actually do a referral or an e-consult to our endocrinologists. And it starts off with, down here, referral type, where you can actually say, I want an e-consult, I want a referral, and then actually moving forward, possibly specialist to specialist referrals to try to create virtual multi-specialty clinics. But right now where it is it actually puts that primary care and that patient in control of the level of care, and that's based on their comfort level and their previous experience. And so they put in an order, they decide, I think this is a quick question, I just need to get a little insight and make sure we're moving in the right direction. Let's click on e-consult. Then there's always that possibility that that question might be more complicated than anticipated, or there is data that is giving that specialist a little bit of concern that maybe that patient needs to be moved into more of a traditional delivery healthcare track. So the primary care, they can choose to say, I want you, if you can't answer that, just route it back to me. Let me think about it. Let me see what your feedback is, versus, hey, if you can't answer it, just book my patient. So that's the next box that they click through. And then lastly, what is the clinical condition? And from that, clicking the box on the clinical condition, they're able to then move into what looks like a decision support module.
Dwayne, I just want to add one point to this slide. It's not illustrated here, but next month, we are modifying our build where the PCP has to get patient consent for to send an e-consult. Right now, they don't because we aren't billing for e-consults. We'll get into that in a little bit. But that route back to me, or that go ahead and schedule the patient for an in-person visit, is important, because if the PCP is charting after hours and thinks that an e-consult will be valuable, but they don't have the patient consent, they can't send that quite yet. So there will be a checkbox, but that's the importance of that specific option there, is perhaps the primary care doc hasn't had time to discuss sending an e-consult with the patient quite yet.
And that references back to, when you go back to our timeline, this was started before CMS released their guidelines for billing on e-consults. So we're just changing with the time. So let's say that I am a primary care doctor and I've put in that my question is about thyroid disease. Now, here are some questions that are important for the triage by the endocrinologist. Meaning, hey, if they're having eye symptoms, that's somebody that we might consider bringing in, because we need to actually measure if there's exophthalmos. If they're having muscle weakness or twitching, that's going to take us in a direction looking more specifically for Graves' disease, et cetera, et cetera, et cetera. But the most important box on this, my clinical question, it's the only hard stop that we have on this. And that really is to foster that level of communication. As a specialist, I hate it when somebody comes in and it just says eval and treat. What does that mean? What am I evaling? What am I treating? I need to know what your level of concern is. And furthermore, I need to actually make sure that there is actually, your agenda is in line with the patient's agenda. I have actually two constituencies when I do a consult. One is the primary care doctor and the other is the patient. It's not just the patient. If you send me your patient, I need to know what your question is so I can actually respond and create a collaborative care environment. The worst thing in the world is a patient coming in saying, I don't know why I'm here and I don't have a question. And yeah, I can look at some labs, do an exam, but there's a good chance that the answer that you get back is not what you were looking for. And then we've both wasted the patient's time and increased overall cost of care because of the redundancy of testing. Now, moving further down, what this next piece is we actually, listening to our specialists, embedded data capture regarding what are the most recent labs that are relevant to the requested question. So in this instance, I can see, when was my last TSH ordered? And if it's not up to date, then actually I know that I need to go update that. But then also as a primary care doctor, I can look down and say, oh, they want to see a free T4. They also want to see a last T3. And then external results. If my data isn't readily available in the electronic medical record so that it can have an automatic upload, then I briefly just say, all this data is available in the media tab or in my last note. It actually increases the efficiency of our specialists, but also make sure that we're not missing data that the primary care physician thinks is relevant and important.
Those labs or procedures or those results are within Epic. They pull it out into these sections. So that's one of the nice enhancements, which requires much fewer clicks for the PCP. So it does pull in automatically if those tests have been done.
I'm a firm believer that decreasing redundancy of testing is going to be one of the ways that we most effectively decrease the overall cost of care and total cost of care. And that is actually going to come from decreasing testing redundancy. So having these templated responses allows your specialist to know where in the chart the data is, and then obviates the need for repeat testing. So I want to go over then how it works from the specialist standpoint. It really comes down to 3 easy questions when I look at an e-consult. Is this a question that I can answer? Is this something that is not even within my specialty, or the question actually is not able to be answered by the data available? Or is this somebody that's going to actually have a better clinical outcome if I see them on site? So if I'm working in my typical in-basket queues, e-consult has its own field, and you can click into that field, and then you see a queue of the different e-consults that have come in. It's very easy then to click into that existing e-consult, and there you are. You have an overview of who the patient is, 70-year-old female. Can you look at their diabetes meds? And the question really comes out to, I would interpret that as a specialist saying, are you doing everything you can to control that patient's diabetes? Now, that might not be the right question. So let's move to the next slide. When I respond, what we do is restate the question. So if something is a little bit vague, like, can you look at their diabetes meds? It's really not helpful for me to say yes and then bill and respond. That would be a bad program. And in fact, Matt and his QA team would come back and rap me on the knuckles. So what we try to do is really say, okay, I think this is your question if it's not totally clear. If it's a very concise question, I'll even cut and paste that field. Restatement of the question, I get your question, and this is how I'll answer it. In this one, I would respond, is the patient's diabetes management optimized on their current medications? Then it goes directly into a concise recommendation. Yes or no, and then my statement of why. But then because we're an academic medical center, we also have fields where we will put in citations, we'll put in the data that we find germane, because that actually comes back to the other point. Eventually, over time, the goal is that this is a workforce multiplier. I want people working in the primary medical home to know what I know as well. I want this to everybody working at the top of scale. And so I'm going to spend a little extra time as a specialist to give concise recommendations and education about what I'm thinking, because that's going to help us when we manage our next patient together. Then lastly, we go over a contingency plan. Let's say you try this and it doesn't work. Well, then what are your next steps? What is the inflection point to say, you better just send in a referral so I can help you with that patient? Or what are some other likely outcomes if we make these changes that I want you to watch out for? And this is the testing that you should do. So if I look at this and say, wow, this is not something that I understand, this is not something that I even see, I will actually go into a easy, simple drop-down to be able to say why I'm not going to be responding to this e-consult, and then expand on that. So if it is insufficient information, please revise and resubmit the e-consult. I'll put down the data that I need to see to be able to answer your question. Ostensibly, that should be an e-consult, but really our goal is to expedite care and to decrease the total cost of care. So churning an e-consult with multiple iterative responses is not best practices. And once again, we have our QI/PI team that would give me some constructive feedback if I was declining and creating an iterative circle multiple times. Next is logistical question. If you're asking, should the patient be seen or not, I can look at it and quickly tell you yes or no. But that, once again, should not be the nature of an e-consult. Unclear question, in those instances where I'm really not sure what you're asking, I'll try to say what I think the question is, but I'm going to need them to resubmit with clarity in terms of to make sure that I am answering both their question and the patient's question. So lastly, if that primary care doctor said, if you can't answer this question, just get him into clinic, it is really a two-step process where I actually just say, yes, convert this to an enhanced referral, and then I message my front desk, book this patient in next available. And then it's off my desk. It literally took me 10 seconds to be able to say, this patient's best care is going to be on site and in my clinic, as opposed to keeping them in a primary medical home where everybody already knows them and can continue the high level care that they've been receiving for years.
Our practice is to have 2 or 3 specialists within each specialty answering e-consults. The reason we go to 2 or the 3 is we want consistent messaging in terms of responses. And we also want coverage, of course, if 1 or 2 providers are out of office. But expanding this to more than 2 to 3 providers can be a little bit more complicated, some additional training, as well as different perhaps recommendations on how to treat particular conditions versus having consistent messages that PCPs get used to seeing. And then they can start creating a data or a dictionary or a log of e-consults they've sent to be able to reference in the past on how to address those clinical questions that they may have already asked to be an e-consult, in hopes that eventually those PCPs will stop e-consulting on the same clinical question over and over again because they have the same response from the consistent specialist in each specialty. I'm going to jump into some of the outcomes from our e-consult work, specifically focusing on patients and looking at indirect and direct cost savings from an internal cost calculator we created. When we look at cost savings across all payers, public and private, $60 per e-consult in direct cost savings to payers, and $40 per e-consult indirect cost savings to patients. And obviously enhanced referrals increased first visit efficiency because, as Dwayne showed in that illustration earlier, those PCPs, when sending an enhanced referral, they follow the structured template, the same template that they send an e-consult with is the referral template that they now use. So they're creating an enhanced referral with a clinical question, with labs, tests, and imaging that have already been done to allow for the most efficient first visit to the specialty. In terms of quality and looking at our data, 2.5% of answered e-consults resulted in an in-person visit within 30 days. That's a pretty good number. That's for any diagnoses. When you actually look at the specific referral within 30 days post e-consult for the same diagnoses or the same condition that the e-consult was placed on, that number actually goes closer to 0. And none of our patients that had an e-consult placed have ended up in the ED within 30 days of having that e-consult placed. Another really good quality measure there. We have plans to evaluate e-consults. We're actually working on a few publications now. We're evaluating e-consults and direct correlations with the Project CORE program on no-show rates, on improvement in referral completion, and on improvement in access. Various publications nationally do show a correlation between those 3 things. We're in the process of evaluating that for Anschutz Medical Campus. So it comes for providers. We have gone through a few iterations of primary care and specialist provider satisfactions. Great results. The average specialist can complete an e-consult in 10 to 15 minutes. So that's very valuable in terms of being able to answer 4 or 5 of those in an hour and generating work RVU to the specialist as well as revenue to the department, which is funded internally right now until we begin our e-consult billing efforts later on this year. The key goal of all this from a provider satisfaction is that they believe that e-consults, both the primary care provider and the specialist, believe that e-consults help treat the patient and keep the patient in the primary care medical home, which equates to treating the right patient at the right time, in the right place, and providing them the right care. I'm going to turn it back over to Dwayne to wrap up on an opportunity for statewide rollout and conclude this program.
I'm going to add in the right data as well. I mean, and of course it depends on the specialty, but you know, there's having that highly templated platform that really says, this is the data I need to do my job, and being able to answer those questions with the right data. Nobody likes to be inefficient. Nobody likes to not have what they need on hand to do what they've trained to do for years. And so It's just such a great level setting. And I can't thank the AAMC, as well as my own institution, enough for their partnership. There's nothing secret in the CORE. It is just, Project CORE is just another e-consult program. But really what they focus on is changing the culture in your institution. It's about collaboration. It's about recognizing that we can all work together to weave in e-consults as part of a larger care spectrum, a rational care spectrum, where multiple levels of care are available for primary care providers and their patients to choose from, including virtual visits, either in the clinic or at home, including e-consults, including echo, because not every patient is going to need the same level of care. And you need to have that place to start from to define that. So we've been successful in community engagement and developing community demand. Matt already touched on our burgeoning project with our local FQHC. And we actually, when we look at expansion, we're having to define what is your EHR. EHRs are defining what is your care network. And so there are practices that are part of the University of Colorado Health System and their clinically integrated networks that are on our instance of Epic. Well, that's defined within our scope, and actually nothing much extra is needed for them to come on live with e-consults. Then that kind of next concentric circle out is Epic to Epic e-consults, and that's still being worked on in Wisconsin, but there are multiple programs in the state of Colorado that would love to partner with our children's hospital, love to partner with our academic hospital to provide select e-consults for those harder to access specialties. Then lastly, then trying to tackle EHR to EHR integration. And Matt touched on a project that we have ongoing that is working through single sign-on to provide interoperability through a third-party platform. So really the goal is when we look at the state of Colorado and eventually in the Rocky Mountain region, we want to be able to provide high level of healthcare at the level requested by the patient and the primary care, recognizing that not everybody needs to drive 7 to 8 hours to have their labs reviewed. We were lucky when we started this. We were lucky that CMS finally came through and developed their interprofessional internet consultation codes. And so now we can move forward to sustainability, towards sustainability with appropriate billing, because it needs to be done on both sides. Primary care needs to be compensated because they're going to be acting out the plans. Specialty care needs to be compensated for their professional knowledge and their work. Third-party payers are starting to provide reimbursement. Most places that have been successful to date are in the value-based payment models. It is much easier to show that you are saving money by decreasing your specialty care consults, but there's also research that we've done that shows if you focus on a higher or more complex patient base in your non-procedural specialties, that you actually drive a significant downstream revenue that previously would have been diluted out by seeing patients that don't require further testing. So we believe, and we have data that suggests that this also can be appropriate in a traditional fee-for-service model. So the next steps, as I mentioned, we're looking for bidirectional PCP and specialist communication in this templated format across EHRs, working through the processes to get patients consented if they're not in the clinic at the right time, and then also working on revenue cycle information exchange, because to be able to bill for it, and if you're in a different EHR, you have to know what the billing data is. There needs to be professional billing. There needs to be also technical support to fund the ongoing QA, PI, and platform maintenance. And as you grow, you will always need to continue to recruit and engage specialists in the higher requested specialties. And that has some growth challenges that we have had fun addressing over the last 2 years. Lastly, one of the two areas of growth that we're really thinking is interesting is the idea of inpatient e-consults to be able to address questions that might not need the specialist walking into the hospital. And this has really been prompted by the COVID crisis. And then also limited expansion into specialist to specialist e-consults. But at the same time, it's a double-edged sword when we look at that, because we don't want to bring the primary care provider out of the primacy, out of the center of our communication. I think we're open for questions. What do you think, Matt?
Yeah, open for questions. Happy to answer any questions you guys have. And here's our contact information if you want to reach out to us. But that being said, we'll open up for any questions.
Thank you, Matt. Thank you, Dwayne, for the great presentation. We did have some questions come in, so definitely appreciate you guys also answering some of those during the presentation. So thank you for that. And again, thanks for joining us. And Dwayne, I think you're on mute there. If you just want to go ahead and unmute, we'll get you on live with us. The one of them that came in.
Dogs here, so you know it's.
Oh yeah, feel free to mute as much as you need to.
Come off mute.
Yeah, no worries at all. So the first one that came in, well, we had a bunch of them come in, but one of them was from Amy and Corey. They were asking about. Actually, I'm sorry, it was from Corey and Catherine. They said, you may be getting to this, or I missed it, but is there a charge for e-consult? And then how do the specialists bill and receive payment for these e-consults? Oh, yeah, did you guys?
Yeah, I can take
Oh, go ahead. There you are. Sorry about that. I think it cut out for 1 second.
I think we both froze time. And so it's embedded in our typical billing framework in terms of in Epic. You know, we initially started off with it having built into other contractual relationships. It was not a strict billing, and we were using dummy codes. But as we have had successful payer engagement, we have been able to now have it more part of it. If you look at the CMS guidelines currently, a little bit of a challenge on the primary care side, because they need to attest that 16 minutes were spent in communication with the patient and uploading of data, completing the e-consult for that to be a billable service. A lot of our primary care physicians don't feel that it really takes 16 minutes. We still have an RVU system running behind the scenes, so they are not typically billing for that directly to CMS, but they're still getting RVU benefits for their time and service. I think in the long term, I know there's a lot of activity trying to get some of those guidelines changed to make this a more sustainable and engaging process for primary care. Because if they're willing to take energy to manage these patients in primary medical home, it has, or you know, a lost leader.
Okay, thank you, Dwayne, for that. Anything to add, Matt, or move on to the next one? We got just a few more minutes for questions here, so yeah, go ahead.
Yeah, Andrew, thank you. I'll just add one thing to that. So the floor really is set at a reimbursement to the specialist and PCP at $37. And in Colorado, only Medicare and one commercial planner are reimbursing for e-consults. So we're going to have a mix or a range of reimbursement models depending on the payer, as Dwayne mentioned. So when health plans come on and make e-consults a covered benefit, and we lock into a contract with them, that rate may change, or that floor may change at what we're going to reimburse our specialists at. But right now it's consistent 0.7 work RVU and $37 to both the PCP and the specialist.
Great, thank you, Matt. And then there were a couple other questions. I think you guys already answered this if anyone saw it, but there was some questions about which platform are you using for non-Epic users, and it sounded like Arista MD. And then there was a question about addressing risk and liability concerns for providers. And I think you guys mentioned that there's legal disclaimers that you guys have for that.
Yeah, there's a lot of legal disclaimers. That has to be state by state as well, because different states have different laws as to if you have established a patient-provider relationship. And in Colorado, communication between a primary care and specialist does not constitute establishment of a care relationship between the consulting specialist and the patient.
Great. No, thank you.
Add in one thing.
Yeah, go ahead.
Is we've talked a lot about the value of e-consults, but one thing we didn't really touch on is e-consults really replace the model that a lot of people are continuing to work under, which is curbside consults, right? So we've created a model of e-consults that take uncompensated and undocumented work and creates compensation to the PCP and the specialist while creating a documented encounter with an Epic. So we've been able to see phone calls, curbsides, emails to specialists decrease drastically because now everything's being routed in the e-consult.
Great. Thank you, Matt. Thank you, Dwayne, on that. It looks like we're kind of up against the wall in time, so this will be the last question. How has this been received by PCPs, and has there been concerns from them on this just adding more work to their workloads?
We can answer that both in terms of our local experience, but also there's been publications on that question. And I'll cover the publication piece of it. And that was a study that was done out of LA Cares that showed the majority of consulting primary care physicians felt that the increased access and increased help in management of their patients more than offset the work shift that is inherent to this. So yes, you will get recommendations back. You need to act on those recommendations. That is a task shifting. However, that still occurs even with an on-site or face-to-face typical brick and mortar consultation. So that's not really that different, but it was about, I think it was, if I remember correctly, about 30% of primary care in that study out of the LA Care system, which is the county system in Los Angeles, did feel that there was a certain level of task shifting. So it doesn't go without pushback, but Matt can speak, I think, more to what we saw on our.
Yeah, so we've had nothing but positive experience. We've actually surveyed our PCPs more than once, and it was over like 95% of the PCPs in the survey of 50 or more PCPs said they love this model. They would have sent a curbside or a curbside consult if this wasn't available for them. And the reality is the PCPs actually like treating the patient in their primary care center. And they're also learning from the specialists on how to treat these conditions in the future. So they're getting more well-rounded knowledge that perhaps they don't experience often due to these unique perhaps situations where they have to e-consult with a specialist. But for us, our PCPs are on board. We've had over 60% send an e-consult. And of that 60%, I don't know the exact percentage, but definitely multiple users and nothing but positive experience to date.
Great. Well, thank you both, Dwayne and Matt, for the wonderful presentation. We absolutely appreciate it, and thank you everyone for joining us. Your guys' contact information is in the slides if people need to reach out for additional questions, if we didn't get to everyone's. And remember for everyone to visit the Solution Center to find partners that will address this topic in today's session. So thank you all for joining, and have a great rest of your time.